Hello to everybody. Welcome to the first EDTNA ERCA webinar related to vascular access. For technical reason, we cannot see each other. We were supposed to have a webcam, but you can only hear my voice and not see me. But for sure, this will not be a problem. I saw in the participant list that there are some people that attended already previously to this presentation. So this could be considered a sort of repetition, but you know, as the Latin were saying, repetita iuvant, that means repetition can be beneficial because of course we can understand better certain aspects of the presentation and we can remember it better and then transforming it or applying it in the real life. Vascular access topic is very important for the nurses. I think that is one of the most important responsibility that the nurses are having. We really have the full responsibility of preserving the patient lifeline because of course the surgeon and the nephrologist, they are caring to create the vascular access and to take care of the complication. But the person that is really daily touching the vascular access of the patient is the nurse. So it's a very important responsibility and we have to be aware about it. And we have to take it into account and do our job properly to make sure that the patient outcome is going properly. Before starting with the presentation, I just would like to give you some information, let's say, of participant rules. So all of you are automatically muted by ourselves. So please do not mute your line because we are doing it. And we are muting everybody to make sure that there are no disturbances and that the voice of the speaker is listened properly by everybody. If you want to ask a question, you should raise your hand. You can see here that there is an icon. In this icon, you click on this icon and we see who of you would like to put a question, and then we will open your microphone. In case you don't want to raise your hand, you have the possibility to write a message here. You click on the question mark and then you can write your questions here. We will read the text and answer accordingly. We also would like to tell you that the presentation of today is being recorded and will be available on the EDTNA ERCA website soon in the next days. So let's start now with the presentation. But before that, I would like to introduce myself. My name is Maria Teresa Parisotto. I'm Chief Nurse Advisor in Fresenius Medical Care. I was working in dialysis in the last 35 years, or probably even a little bit more. And the last 8 years of my professional life were dedicated in the clinical research and investigation about vascular access and the impact of the nursing procedures on vascular access survival. During the presentation of today, we will show the results of our investigation. So preserving the AVF as the patient lifeline, we can see here in this data coming from Australia and New Zealand that the AVF reduced the patient mortality compared to catheter. So you can see that a patient with an AVF has a much longer life compared to a patient with a catheter. If we look at the DOP study, in 5 European countries, France, Germany, Italy, Spain, and UK, we can see that the vascular access related cause of hospitalization is the most important. You can see here how important is the cause of hospitalization related to vascular access in these 5 countries. And if we look at the complications associated with vascular access cannulation, in this publication done in 2001, it was the thesis of a nurse, thrombosis represent 16.5%, hemorrhage 7.5%, infections 5.5%, and aneurysm 4.1%. So for all the reasons that we saw in the previous 3 slides, we can understand how important is the preservation of the vascular access, and it is definitely our responsibility. And when I'm saying our, I mean nurses' responsibility. If we look at the different phases of the vascular access management, we can see that we have the creation, first of all, and this is normally done by a vascular access surgeon or a nephrologist. We have the assessment and preparation of the vascular access. We have the cannulation. We have the monitoring during treatment, disconnection, so needle removal, and then we have the hemostasis. All these phases, particularly the one related to surveillance and hemostasis, are in the hands of the nurses and the patient. Vascular access creation, of course not. To better understand how the cannulation technique was done in Europe in the dialysis center of Fresenius Medical Care, so the nurses team of Fresenius Medical Care decided to do a survey in Europe, Middle East, and Africa. The objective, the study design was very simple. A snapshot of the current practice of vascular access cannulation. The design was international, multi-center, observational, and cross-sectional. The center were the one of Fresenius Medical Care, Europe, Middle East, Africa, and the participation was on voluntary basis. The procedure was the anonymous documentation of vascular access and its cannulation once per patient, so the patient questionnaire, at an appointed day that was April 2009. The inclusion criteria were very simple. Patient treated with hemodialysis and hemodiafiltration during the week of the survey. Double needle hemodialysis, so single needle was excluded. Via native fistula or graft, so patients with catheter were also excluded. And here we can see the countries participating in the survey. 10 countries, 171 centers, 10,807 patients were involved in the survey. You can see there was UK and Ireland, Spain and Portugal, Italy, Slovenia, Poland, Romania, Turkey, and few centers from South Africa. So we can say that the picture coming out from this survey is really representative of Europe. Let's go to see the results now. And here we have the descriptive statistics. You can see that the AVF, the patient with AVF were 90.9%, AVG 9.1. The location of the fistula was in the arm, 98.7%. In the left arm, in 72.2% of the patients, and the lower arm in 49.6% of the patient. I have to say that this was the first results that surprised us, in particular surprised me, because being a nurse that started to work in dialysis 35 years ago, I was really surprised that to have so few fistula, AVF, let's say, in the lower arm. There were much more 35 years ago, at least 70 or 80%. But of course, meanwhile, the population changed, the dialysis patient became older, then the vascular access of the patient is weak, let's say is not lasting so long anymore. Not only, also some procedures changed, because nowadays the vascular access surgeon are doing the fistula, while in the past it was done by the nephrologist that was for sure caring much more to have a functional fistula. Cannulation technique, this was the second surprise to see that 61% of the patients were cannulating using the ERCA technique. ERCA technique in Europe, what in North America they called one-site itis. Rope ladder, 31%, and buttonhole, 6.1%. And there are, of course, missing data. We were surprised to have so many patients cannulated using the ERCA technique. Of course, the ERCA technique is the easiest one, but for sure is not the best one for the patient outcome and for the survival of the vascular access. Needle size, you can see in the majority of the cases, 61.3%. The 15 gauge needle was used, 33.2, 16, and then there was a minority using either 14 or 17 gauge needles. The direction of the arterial needle puncture was antegrade in 63% of the cases. Antegrade means in the direction of the blood flow. The orientation of the bevel was upward in 72.3% of the cases. Another question that we were asking was if the needle was rotated, particularly the arterial needle in this case, immediately after cannulation. And we were asking this question because in the past it was a common practice to introduce the needle with the bevel upwards and then to rotate the needle, because with the bevel down and the needle not having the back eye as they have today, it was possible to have a better blood flow. But of course, this is a procedure that should not be done because it is damaging the intima of the vessel. And we will see in the next slides how much the needle rotation is damaging the fistula. We also ask information related to nurses' experience in dialysis, and you can see that 66% were having more than 5 years of experience and 19% between 2 to 5 years. It means that 85% of the nurses were having more than 2 years of experience on dialysis. So with the data that we collected, we did 3 types of different evaluations, of different analyses. First of all, we analyzed the variables possibly influencing the probability of reaching an adequate dialysis dose. That means a KT over V equal or above 1.2. Then we were analyzing the nursing practices possibly influencing the development of acute cannulation complications, such as multiple cannulation, infiltration, hematoma, hemorrhage. And the third one, and the most important, I have to say, is the cannulation technique versus vascular access survival. In this case, we followed up for 3 years, 7,058 patients. Why is this also very important? Because if you go and look in literature, you do not find publication comparing cannulation technique versus vascular access survival. Why? We can speculate that the reason for this is because the doctors that are normally used to evaluate the outcome of their job are not cannulating. The nurses that are cannulating, they are not used to evaluate their job. And this is the reason why, really, before this publication in literature, there was nothing comparing nursing procedures, cannulation technique versus vascular access survival. So let's go to see the results of the first analysis, the one analyzing the variables related to the probability of reaching an adequate dialysis dose. I don't want to go through all the details because anyhow, you have the possibility later to download this presentation from the EDTNA ERCA website. I just want to focus on the most important thing. Here is the direction of the arterial needle. We compare the retrograde directions versus the antegrade direction. And you can see that using a retrograde direction, you improve the probability of reaching an adequate dialysis by 27.5%. But here we are speaking about adequacy. We are not speaking about vascular access survival. And the reason why is a speculation, because we would need additional analysis to really give a scientific answer. But probably the reason why you have a better results in terms of adequacy if you insert the arterial needle in the retrograde direction, that means against the blood flow, is because the needle tips between arterial and vein, they are more far away. So you have a lower probability of recirculation. And because of that, you can have a better adequacy. But here we are only looking at the adequacy, not at the survival. I insist on that because in the next slides, we will show that the retrograde direction is not ideal for vascular access survival. So it means that we as nurses have to ask to ourselves, okay, what can I do for this patient? Because adequacy is for sure important, but vascular access survival is extremely important. So we have to ask to ourselves, if I insert the arterial needle in the antegrade, what else can I do to improve the adequacy of dialysis? And the answer is here. Treatment time. This is the most important parameter that we could use to improve adequacy, because we calculated that per minute of treatment, not per hour, per minute, we can increase or decrease the probability of reaching an adequate dialysis by 3.6%. It means that any time when a patient is asking us to be disconnected 10 minutes before, we are decreasing, for this patient, decreasing the probability of reaching an adequate dialysis. So we know that the patient wants to be disconnected earlier. We know that the patient are always asking, let me have 10 minutes less dialysis, please, or let me have half an hour less dialysis, please. But then it's our responsibility to train the patient, to teach them, and to explain them that to be disconnected 10 minutes earlier is not irrelevant. That could create problem on adequacy. The other analysis that we have done was a logistic regression model evaluating nursing practice in respect to the event acute cannulation complications. Also in this case, I don't want to go through all the parameters. I want to focus on 3 of them. One is cannulation technique. We took as a reference the rope ladder technique, and you can see that with buttonhole, you have a lower risk of developing acute complication, and it is statistically significant. But even area, that we know area is really not the ideal cannulation technique for vascular access survival, but in the case of acute complications, you have a reduction also here of the risk of developing acute complications that is statistically significant. Also, in this case, we can speculate the reason why you have less risk with buttonhole and area. With buttonhole, it is clear because you have the insertion point for the needle, they are defined. You have a track, let's say, to follow. So it is not so, normally you do not do mistakes with it. With area, since you focus your cannulation in a specific area, let's say in a specific zone, also in that case is easier to find the vessel. While with rope ladder, since every time you have to change, the cannulation site, you run the risk to have multiple cannulation or cannulation failure, particularly if you are not experienced. And here come the point related to know-how, knowledge, experience, expertise, training. We really need to be well trained when we go to cannulate a vascular access. The other point that I want to focus is the needle axis rotation. As I said before, that in the past particularly, but still today, sometimes we insert the needle bevel up and then we rotate the needle. And you can see here, if you rotate the needle, you have an increase of risk of acute complications development by 52.2%, statistically significant. So we really have to be careful. And if we are convinced, and sometimes it's true, that with the bevel down, we have a better flow, we should cannulate the fistula directly with the bevel down and not to do the rotation. Also because by rotating the needle, you run the risk to infiltrate the needle, you run the risk to damage the intima of the vessel. Another important point is the needle fixation. We took as a reference the butterfly technique, that means to put the tape all around the wings of the needle, because butterfly, it was recognized, at least in the past, as one of the safest needle fixation to avoid dislodgement. But if we compare the butterfly with chevron, you can see that with chevron, we decrease the risk of development of acute complications, and even with the U shape. But no one of them is statistically significant, so we can only speak about a trend, but not really about significance. We have a result that is statistically significant by using the technique other, where you can see you have 44% reduction of risk of acute complications, and it is statistically significant. Now you could say to me, okay, but other, what it is other? Of course, we did a second investigation to understand the meaning of other, and we discovered that it was a simple modification of the U shape, that we could call it V shape. So with the V shape, there is a very important reduction of risk of acute complications. Now, let's go to see the cannulation technique versus vascular access survival. So out of the original 10,807 patients that were enrolled in the survey, we were having access survival data available for 7,058 patients. The primary outcome of this study was the time of the first surgical access intervention, where the date of the survey served as a baseline. The observation period was 3 years, from April 2009 till March 2012. And to adjust for individual patient differences, we were extracting the following data from the database: patient age and gender, BMI, prevalence of diabetes, use of ACE inhibitors, platelet antiaggregants, salicylic acid, and anticoagulants. Let's look now at the descriptive statistics, and you can see that the mean age was 63.5 years. 38.5% were female and 27.1% were diabetics. 90.6% had a native fistula and 9.4% a graft. 51.2% of the patients had a distal access location. 51.1% were treated with antiaggregants and 2.8% with anticoagulants. The needle used, 63.7% were using 15 gauge needle, 32.2% the 16 gauge needle, and then a minority was using 14 gauge or 17 gauge needle. And look here about the cannulation technique. Here we were even more disappointed because 65.8% were using the area technique. Area technique is called in Europe, in North America is called one-side itis. I say that because probably there are some people from Canada or US participating to this webinar. The rope ladder technique, 28.2% and buttonhole 6%. The direction of the arterial puncture was antegrade, so direction of the flow in 57.3% of the cases. And the prevalent combination between arterial needle puncturing and bevel direction was antegrade with bevel upwards in 43.1% of the cases. The median blood flow was between 350 and 400 milliliters per minute. So we did a Cox model with primary outcome vascular access survival. Many of the information that we have here, we knew already. For example, we know that in the male, the vascular access survive better than in the female. For sure, if you are a diabetes or if you have heart failure, obviously your vascular access survive less. We also knew that the fistula survive better than the graft, and the fistula in the left arm survive better than the right arm. Here, our colleague from North America would say, why in the left arm they survive better? Okay, because here in Europe, the majority of the people are right-handed. So left arm means non-dominant arm. And we also knew and know that a fistula with the lower arm location survive better than a fistula with the upper arm location. But now I want to focus on something that probably is not so known. For example, needle size. We took as a reference the 15 gauge needle because it's the one most used. And you can see that if you use a 14 gauge needle, you have an increase of hazard ratio, that means an increase of risks, by 25%, although it is not statistically significant. So we can only say is a trend, but we cannot really confirm it scientifically, at least for the moment. If we use, at least in our study, it also came out that by using the 16 gauge needle, you have an increase of hazard ratio by 21%. In this case, statistically significant. And now, of course, the question is, why should be a fistula at risk if you use the 16 gauge needle? We do not know. We would need additional investigation to answer scientifically to this question, but we can speculate that most probably the patient using the 16 gauge needle were already having a not perfectly functioning fistula, and for this reason it ended up earlier. Cannulation technique. We took as a reference the area because this was the one that we were using most frequently. And you can see that if you use the buttonhole technique, you have a decrease of hazard ratio by 22%, statistically significant. Even with rope ladder, we have a decrease of hazard ratio by 11%. And in this case, let's say we are at the limit, at the border of significance. But of course, also the information is not new. What about the blood flow? We took as a reference a blood flow between 300 and 350. And you can see that even if you use a blood flow between 350 and 400 or above 400, you do not have an increase of hazard ratio. On the contrary, you have a decrease of it. Although, if you look here, both these data are not statistically significant. Arm compression at the time of cannulation. We took as a reference patient assistance. That means the patient that is compressing the arm to engorge the vascular access. And look what happened. If you use the tourniquet, you have an increase of hazard ratio by 30%, statistically significant. What does it mean? That the tourniquet is bad, that we should not use it? No, this is not the meaning. The meaning is that the tourniquet should be used properly. First of all, the tourniquet should not be too tight, because if it is too tight and you block the flow inside the vascular access, this can create damage. Second, the tourniquet should be used just for the time of inserting the needle. It means put on the tourniquet, insert the arterial needle, remove the tourniquet, fix the needle, then put the tourniquet again, insert the venous needle, remove the tourniquet, and fix the venous needle. Sometimes you see that the nurses are putting on the tourniquet and they leave it till they inserted both, not only inserted and fixed both needles. This means a minute. And if you leave the vascular access without flow for 1 minute, of course you can have problem. And you can create damage, and then you run the risk to increase the vascular access failure. Direction of the arterial needle and the bevel. So you can see we took as a reference the antegrade direction of the arterial needle, because venous is always antegrade, with the bevel upwards. And if you use the antegrade direction with bevel downwards, bevel down, you have a slight decrease of hazard ratio, although it is not statistically significant. But what for sure is significant is the retrograde direction of the arterial needle with bevel down. You have an increase of 18% of hazard ratio, and it is statistically significant. Here, the data that was really surprises us most, the venous pressure. We took as a reference the venous pressure between 100 and 150 millimeters of mercury. And you can see that already by using a venous pressure between 150 and 200, you have an increase of hazard ratio by 40%, statistically significant. Between 200 and 300, you have an increase of hazard ratio of 87%, statistically significant. Not speaking about a venous pressure above 300 millimeters of mercury. So what can we say in summary, the results of this study related to vascular access survival? That the area cannulation technique, despite being the most commonly used, was inferior to both rope ladder and buttonhole for the maintenance of the vascular access. And with regards to the effect of needle and bevel direction, the combination of antegrade position with the arterial needle with bevel up or down was significantly associated with better access survival than the retrograde positioning with bevel down. And the other results, let's say, coming from type of vascular access, location, etc., there was an increased risk of access failure for graft versus fistula, proximal versus distal location, right arm versus left arm, and the presence of a venous pressure greater than 150 millimeters of mercury. So the results of the venous pressure are really worth considering, because a venous pressure between 200 and 250 millimeters of mercury is, or I would say now was, considered acceptable by the scientific community. But the results of this study put this value under discussion. However, to confirm it, really further investigation to clarify fully the topic are required. And this is the end of the first part of this webinar. You know that the 1st of June, we will have the second part with additional very important information. But now it's time for you to raise your hand and to ask the question. Or comment, of course, you do not need only to ask question, you can also commenting in the presentation, or you can share with us your opinion or your experience. No? Nobody? I cannot believe that.
This morning.
Well, do you know that this morning we had half an hour discussion after the presentation?
Okay, Anna. There is a question from Anna.
There is a question from Anna. The microphone is open, please. So here there is a question mark from Anna. Why is 16 gauge higher risk? Well, I told you, we do not know. We need to do additional investigation to understand, but we really do not think that is the 16 gauge needle per se the problem. But probably 16 gauge needle was used in patient with already, let's say, vascular access with some problems. So we really would need to do additional investigation. But although, I mean, I have to answer scientifically, this is a speculation. I don't think that the 16 gauge needle per se is a problem. Or it could be, and this is maybe something that we will develop even better in the next webinar, it could be because if you use small needle and a high blood flow, it is unavoidable to have high venous pressure. Then there is another question, experience with catheter cannulation. This is Anna Meisoso. No, we didn't have any catheter cannulation, so I cannot answer to that.
Another question.
Another question, Ildur, is thank you for the interesting presentation. When will the presentation be available on the website? Well, we need probably 2 weeks to have it there. Yeah, there is another question, but no, but I was just wondering why all the people is writing the question instead of using the microphone. Marika, because here the questions are a lot. I can see that all the information that you have shown us are similar to our small unit in Malta. Oh, good. I would like us also to be included in another study. Thank you for the interesting lecture. Okay. Irmina, where is it?
I open up for Irmina. Okay.
Irmina, can you speak?
Yes, I can speak.
Yeah, good.
I want to write down. Do you hear me well?
Yes, perfectly.
Just my question is, if I missed, what your experience about using static clamps for hemostasis and vascular access survival?
Well, we didn't do this evaluation, so I can only speculate, or I can tell you my opinion, let's say my opinion. I mean, the devices that we have today, where we can regulate the pressure, I think that they can be used. Because the important is really to regulate the pressure. Because also during hemostasis, you should never press too much to block the flow inside the vascular access. And with the devices of today, this is possible. With the devices of 35 years ago, no, it was not possible. But with the devices of today, yes, you can.
Okay, thank you.
Of course, it's always better the manual pressure, but if you cannot, for whatever reason, we know that the dialysis population nowadays is getting older and older, and maybe they are even not able to do it by themselves, then you can use this new device, regulating the pressure, making sure that you always have the flow present in the vascular access.
Okay, thank you. And another one question, may I?
Yes, yes, sure.
Maria, what is your suggestion regarding the optimal, not the optimal, but the highest venous pressure and the highest arterial pressure, which is not influencing the damage of the vascular access?
Look, arterial pressure, we were evaluating it, and arterial pressure doesn't have any influence on the vascular access survival. At least in our Cox analysis, nothing came out. And also because you have to consider one aspect. The machine, dialysis machine, I mean, they are much more, they react faster in case of a high negativity, let's say in the negative pressure, than in the case of the venous. Because if you do not have flow, you have more or less immediately or very soon or very quick an alarm from the machine. While in the venous pressure, the reaction of the machine is not so quick.
Yeah.
And probably this is also one of the reasons. But to give you exactly the limits, as I said, for arterial pressure in theory, you can have also minus 250, although personally I think that we should never have more than minus 200. For venous pressure, the ideal is between 150 and 200. It is almost impossible to have a venous pressure lower than that, particularly if you run with a blood flow of 350, 400 milliliters per minute. But you have to adapt also the dimension of the needle, not only to the anatomy, let's say, of the fistula, but also really to the blood flow that you want to reach. And in the next session, I will explain you why in a very simple way with some in vitro analysis that were done not by us, but by a company producing needles for sure.
Okay, clear. Thank you very much. That's all from my side.
Thank you. Experience with echo Doppler previous cannulation, not in this study, so I cannot tell you anything. For sure, with echo cannulation, you can avoid some of the, mainly the infiltration, you know, to go on the backside of the vascular access wall, fistula wall, but we do not have experience because no one of the participants in this study were using the echo Doppler or the, let's say, echo guided cannulation or ultrasound guided cannulation. So if there are no other questions, I just would like to show you a slide, the next slide. And these are some of the topics that we will discuss next time. So how can the bevel orientation influence the vascular access survival or the angle of the needle inside the fistula? And this one, that is the one that I like most. When did we discover that arterial needle antegrade direction is fistula protective? Just to stimulate, you know, because we really hope not to see you because we are not seeing each other, but to hear from you also next time, June the 1st. There will be one from 10 to 11 and one from 16 to 17. We can now close the webinar and see you or speak together on the 1st of June. Thank you.